Welcome to this special clinical series, From Vascular Curiosity to Neurodegenerative Disease, a consensus statement for the diagnosis and management of MACTEL Type 2. For decades, macular telangiectasia type 2 was viewed as a vascular curiosity characterized by its subtle vascular abnormalities, including telangiectasia vessels and late-stage leakage. Emerging research and clinical consensus, however, have shifted the paradigm of MACTEL type 2 from a primary vasculopathy to a complex neurodegenerative disease centered on the dysfunction of Müller glial cells, which support both the functional and structural integrity of the retina and the subsequent loss of photoreceptors. As the understanding of the metabolic and genetic components of MACTEL type 2 evolves, clinicians are recognizing that standard metrics of visual function, specifically Snellen visual acuity, are insufficient for capturing the true burden of the disease. More appropriate measures include difficulty reading, metamorphopsia, and paracentral scotomas. In this 4-part video compendium, an expert consensus group of renowned retina specialists help us move beyond the traditional eye chart to explore the metabolic underpinnings, multimodal diagnostic protocols, and emerging neuroprotective therapies that are transforming the standard of care. Join us as we explore these perspectives to ensure that no patient is left behind in the Snellen trap. And for more details, we encourage you to use the QR code on this screen to read the full written consensus statement. MACTEL type 2 may cause vision impairments that significantly impacts daily life. Studies have shown that patients with MACTEL type 2 experienced decreased reading capability. Compared to a healthy individual who reads an average of 190 words per minute, those with MACTEL type 2 commonly read about 50 words less per minute. They struggle reading numbers and have difficulty with daily tasks, such as reading medication bottles, computer use, and reading and following recipes. About 83% of patients experience metamorphsia. Some patients may experience socioeconomic burdens during prime earning years resulting from decreased productivity. Lastly, about 24% of patients with MACTEL type 2 report lower mental well-being compared to healthy patients. They may feel like a burden to their partner, become frustrated by their inability to enjoy loved hobbies, and resent their loss of independence.
If you look at some of the data, patients lose on average about 1 or 2 letters of visual acuity a year. And so that adds up. 5 years, you're losing a line of vision, 10 years, 2 or lines of vision. So, when you're talking about reading and visual function, fine visual function, I think you want to maintain that as long as possible.
My patients typically complain of issues with reading and letters of words going missing, letters feeling like they're jumping as well, and visual acuity and central vision loss typically are affected early.
I think that's one of the real difficulties for current diagnostic strategies is that patients have a hard time sort of quantifying what the problem is.
Some of the first symptoms patients may experience can be with driving. Studies shown visual impairments related to MACTEL type 2 commonly cause slower reaction to road hazards and difficulty judging distance, as well as perceived straight lines. Additionally, patients may have trouble navigating roads and reading road signs.
In my clinical practice, patients who have MACTEL type 2 often complain of a difficulty with reading because there are some blank spots in their central vision. They also might have more difficulty adapting between bright and low light situations. At night, it may be harder to drive because of these blank spots in their central vision as well.
I think it's very, very helpful to sit down with them, go over their imaging with them. So one of the real values of fluorescein angiography is that you that's the type of imaging that you can show a patient and they can understand the vascular changes. That seems to be something that even if for a layperson, they can see the differences, particularly if you show them a normal angiogram. As we begin to understand the OCT changes associated with MACTEL, you can also use that to show them the changes in the retina as well. So I think going over imaging with patients initially is incredibly helpful in this disease and others, but certainly in this disease for them to understand what they have and what they have to expect. In general, I've tried to be sort of a glass half full with MACTEL to explain to people that it is a chronic progressive disease. It's very slow progressive. There is a very, very slow rate of vision loss. And so I really have tended to try to give them encouragement, particularly early in the course of disease, because we couldn't do anything about it. It's a very difficult problem. Or I tend to talk more about the progressive changes and the likelihood of functional problems much earlier in the relationship with the patient. I have the conversation about treatment even at diagnosis with patients, even if they're long before a time when they may consider therapy. So I do think my approach to communication has changed a little bit to try to be more proactive towards therapy.
It's important to give them literature. I often, give them a list of, websites that they can go to and they can read, and they take time to digest it. I think that knowing that there's slow progression, but knowing there's a treatment to slow down that progression, I think is really important. And there are people that often just want a diagnosis. They may have had varying diagnoses, uncertain diagnoses in the past, and sometimes people, are ready for a definitive diagnosis so that they can have a label on it and they can start researching it and looking at therapies.
I think it's important to show patients the retinal imaging that they've had over subsequent visits, because that is really the objective way to show them how the retina has changed with MACTEL type 2. We know that eyes who have MACTEL type 2 will slowly over time lose more of their central retina. And we can see this loss of the tissue on OCT imaging, where over time you'll see more of these hyporeflective spaces, more of these cavitations. In addition, we'll see more loss of the ellipsoid zone. And all this is a very educational teaching point for our patients, because they can see over subsequent visits how the disease has progressed. It's important to have a very good and robust informed consent process with any patient who's considering a therapy for MACTEL type 2. The key point is having the patient understand that we're slowing down the rate of the vision loss over time. And I tell them that this can help them see better for longer periods of time, because we know that patients who did not receive the active implant were more likely to lose the photoreceptors more rapidly.
But if they're pretty young, you can sort of show them with an eye chart that in a decade or 2 decades, you're going to be a lot different than you are now, and it would be much better to slow that process down where you continually lose vision on the eye chart. That's the most important. But the reading speed is critical, so you could tell patients that if you're having trouble reading now, that's likely going to get worse without treatment, and the progression of the disease will slow down if you're treated. So I think it's pretty easy to get those points across. The difficult point is that patients will continue to decline even with the treatment. And patients sometimes have trouble understanding that. They think they're getting a surgical treatment, they might get cured. But not only are they not going to get cured, you're not going to reverse the damage that's already done, but they're still going to experience progression of the damage even with the implant. we're pretty confident it's going to be a lot slower. And if it was my eye, I'd definitely have the implant, because I'd rather have slower progression of a problem than faster progression. And that's the thing you have to discuss with them and, repeat it every time they come in, because sometimes patients don't get it the first time.
I think the number one thing is, to manage their expectations around this doesn't reverse, kind of the disease or the symptoms that you already have. It's really about slowing progression. Because sometimes when people will be like, well, I don't see any better. And it's like, well, you're not really supposed to, kind of like, that's not the goal. The tissues and the photoreceptors you've already lost, those are gone and we can't get those back. So we're not really expecting improvement per se, but slowing the worsening. If it's somebody that's already fallen off the edge of the cliff and they're already at 2200 and the entire kind of MACTEL zone has been wiped out on the OCT, there's probably not much benefit for treatment either. So that's kind of like, at the, kind of, there's a little bit of a Goldilocks situation. You don't necessarily want to treat too early, to me, like before there's symptoms, before there's a photoreceptor break, before there's evidence of progression, those three factors that I mentioned. You also don't necessarily need to treat once it's too late either. So, the Goldilocks is kind of in the middle there. I do think we can diagnose MACTEL now super early with some of that temporal thinning.
This disease is often asymmetric. So we tend to want to kind of treat the worse seeing eye first, but even if the better seeing eye qualifies, I would implant it in that eye. And I usually tell them, like, we want to be aggressive in kind of delivering this therapy to preserve vision in both eyes, but even more so in your better seeing eye.
With any ocular surgery, of course, there are risks. And I tell my patients the potential risks for infection, bleeding, dislodgement of the implant, cataract formation if the patient has not had prior cataract surgery. All these can occur at a very low frequency in any eye that's had surgery. I think the follow-up of the patient is important. We follow up the patient in the normal post-operative standard visits, 1 day after surgery, a week afterwards, and then we stretch out the follow-up over time in order to monitor the MACTEL type 2. The good news about the implant is once it's safely employed inside the eye, it doesn't need to be re-administered because it is producing CNTF continuously inside the eye using cell therapy. And this can provide the neuroprotection that the retina needs to preserve the photoreceptors and the tissue from degenerating over time.
I think that it takes some time to get patients comfortable with the intervention in and of itself. But as they get comfortable with that, I talk to them about their functional deficits. I try to help them better quantify where this actually impacts their life, because it doesn't make any sense to have a surgical procedure done with a device that's going to stay in their eye presumably for the rest of their life if they don't perceive much of a change. So I think it's key to have them really try to quantitate in their mind how much difficulty they're having, and then think about what that looks like 3 years, 5 years, 10 years down the road as it continues to worsen. So it's really sort of a two-pronged presentation, and it's not one certainly that is done in one visit or two visits. This requires, I think this intervention requires a fairly long-term relationship with the patient so that they can truly understand the science, the medicine, as well as the disease.
The surgery itself is something we've done for decades for other implants and not anything novel. What's novel about it is that we're delivering cell therapy. We know that from clinical trials, even 5 years out, there was a good production of the protein. The protein helps support the light sensitive cells in the back to, potentially not die off as quickly. And that will help you see longer the quality of vision you have currently.
It's a surgical procedure, of course. It has some risks. I think that it's a relatively straightforward surgical procedure. And I think the risks that we've seen from the clinical trials are manageable. So it's not like we're taking a huge risk for a little benefit. I think that it's a pretty significant benefit for a small risk. So I think the risk-benefit ratio is here. Again, if the patient still has usable vision. If they're at the other end of the spectrum already, they come in with this disease, they've been referred in for treatment, you say, I don't know, then the risk-benefit ratio becomes less beneficial for the patient or advantageous to the patient.
Thank you for joining us for this video compendium on MACTEL Type 2. As we journey from the microscopic failure of serine metabolism to the macroscopic challenges of differential diagnosis and the surgical frontiers of neuroprotection, the goal is clear. Increase awareness, utilize multimodal imaging, and intervene within the therapeutic window to preserve visual function. Thank you for watching this 4-part video series on MACTEL Type 2. By standardizing imaging techniques and refining the differential diagnosis, clinicians can ensure that the transition to neuroprotective therapy is built on a foundation of diagnostic certainty. For more details, we encourage you to use the QR code on this screen to read the full written consensus statement. Together, we can move from passive observation to active preservation.